Really, the demarcation between kyphoplasty and vertebroplasty is more of theory than practicality. Now, if you really understand osteoporosis, it is just the manner in which the bone ages, either because of age or with disease. So, all of us are going to go towards an osteoporotic fracture. Now, whenever you have an anterior column failure, there are certain things that are associated. There's a progressive collapse in the anterior column, which then extends to the middle column and then to the posterior column in osteoporotic fractures. And like Gautam showed, there is always an end plate dissociation which disrupts the nourishment that is coming through the end plates into the disc. So, like I had highlighted, it is very, very important that you monitor all osteoporotic fractures very, very carefully to union, because they always tend to subside. And if they are progressively collapsing and they are going to go towards a progressive kyphosis, there is an first indication of vertebroplasty. The second is what people highlighted. If you do a X-ray in the supine position, you see a cavity which sort of collapses when the patient stands up. So when this keeps happening, there is a progressive osteonecrosis. The pain of the patient tends to keep worsening. The patient is unable to turn and get up. And this is the main feature which actually brings your attention towards a non-union. So this is known by various terms, a cleft sign, an alligator sign. So if you have such a cavity inside the osteoporotic bone, it is invariably a sign of non-union, and you have to fill it up with a vertebroplasty cement. Now, when you look at multiple links in an osteoporotic fracture, if one of the link collapses, then the second is going to tilt over it, and the center of gravity is going to keep falling anteriorly. It's going to predispose a second fracture and the third fracture along with it. So this was highlighted by the speakers below, before me. So if you have a first fracture which you have done an vertebroplasty for, and if you have a subsequent fracture, it can be a natural fracture, or because you have hardened the previous fracture with a vertebroplasty. If you have a subsequent fracture on top of it, then it gives you a reason to give that second fracture adequate stability. So if you have situations like this, you may opt to intervene earlier by doing a prophylactic vertebroplasty rather than allowing that second fracture to collapse. So this is another indication. Now, whenever a spine tilts into a progressive kyphosis, there's always a danger to your neural elements, because these are very, very soft bones and the posterior elements tend to give way quite easily. So you need to be very, very careful. So what are the causes of neurology in osteoporotic fractures? So you can have all these etiologies. You can have a burst fracture, you can have a dynamic buckling of these fractures, or you can have an intravertebral instability, as I have shown in the previous example. This is a typical example of an osteoporotic fracture with a burst retropulsion, and this was stabilized posteriorly with a vertebroplasty filling up the anterior defect. Now one has to understand that the vertebroplasty is more of pain control rather than stability. So even if you have such a solid construct, that construct may tend to pull out over a period of time because of gradual movement. So the osteoporotic fracture has to heal, and that's where the whole debate comes into picture. Now, if you have a dynamic buckling and a collapse which is progressive, then you may actually replace that body with a cage, or you may open it up on table and put a cement in your vertebra plana and stabilize it posteriorly. So you have a collapsed body with a little bit of cement. Now, you may have an intravertebral instability which is going on inside an osteoporotic fracture, and this needs to be stabilized. Now, the most interesting part is that even if you have done a vertebroplasty prior to having that intravertebral instability, you may still have a movement going on in an osteoporotic fracture. So you need to observe your vertebroplasties for a longer time. So these tend to sort of deteriorate over a period of time and result in neurological deficits, which you need to sort of stabilize at a later date. Now, if you have done a vertebroplasty which is a short segment device, the problem is that the device is not strong enough to support your vertebroplasty, and you may have a tilting of the bone around the vertebroplasty as you see here. So vertebroplasty per se has its own problems. The bone may collapse around the vertebroplasty as Gautam has shown in the example before, or you may have an adjacent segment. Now, these osteoporotic fractures can also cause worsening of pre-existing stenosis, particularly in cases like ankylosing spondylitis. So in such a case, nowadays what we do is we stabilize the fracture posteriorly, decompress the spinal cord, and fill up that anterior defect with a vertebroplasty cement instead of a cage, because that becomes a much more extensive procedure where in a patient of ankylosing spondylitis. So this brings to that vacuum sign which Gautam was trying to hint at. So there can be an end plate dissociation in a vertebroplasty fracture and the whole disc has herniated into the canal. In such a case, you do a vertebroplasty. I have some time, right? So you do a vertebroplasty of the fracture, stabilize it, and decompress the spinal cord. So again, a wrong indication is a wrong indication. That means that you need to biopsy if there is any doubt and not end up in situations like this. You can have progressive kyphosis because of subsequent sort of osteoporotic fractures, and these have to be corrected with adequately stabilized screws with cement. But you have to understand that that is not the end of it. This patient was lost to follow-up for 6 years, and this is what happens at the end of 6 years. That means the whole proximal column tilted, but the patient was still asymptomatic. So this brings us to the last slides. That means sacrum. Sacrum is a very, very interesting part because these patients are highly morbid and they are not able to turn and they tend to deteriorate. There is very high incidence of mortality if the patient has a sacral osteoporotic fracture. And sacroplasty is one simple procedure which you can do under a CT scan guidance. You can have a sacral fracture adjacent to your screw, which you can stabilize using a cement again. And these patients are extremely grateful because their morbidity reduces significantly. As a last statement, vertebroplasty is not just for pain. These are elderly patients with high comorbidities, and these comorbidities tend to worsen due to the pain. And you need to intervene as early as possible to get them off the bed on their feet so that their medical comorbidities are controlled. Thank you.